off with some principles of orthopedics first, because the principles of trauma fixation or non-trauma fixation. A little kid comes to my practice today with a broken arm. It's trauma, but it's not sticking through the skin, which we call an open fracture if it exposes skin. Um, and I employ the same principles of open reduction or internal fixation, uh, whether or not it's trauma or not. The only variable that trauma gives is the status of the soft tissue, because bone doesn't heal with an inadequate soft tissue envelope, and that, of course, is the limiting factor in trauma, um, and that's because of infection, right? So let's uh, back up a little bit, talk about a simple fracture with intact skin, and talk about the principles of fixing that. Uh, all through the world, the business of orthopedics makes money by fixing fractures, of course. And but the truth of it is, if I had a simple non-displaced fracture, meaning the angulation is acceptable, the rotation is acceptable on a little person's arm, um, then all I have to do is put them in an immobilizer, and an immobilizer long enough where you immobilize the joint above and the joint below. That's always an outstanding principle to adhere to. You want to immobilize the joint above and the joint below, but not more than that joint. Um, and that's because adhesions, scar tissue, and the like will set in and limit motion probably forever, without an aggressive therapy environment. And nobody on this call except me has access to aggressive therapy after any type of procedure. So immobilization is important, and immobilization has to be thick enough and strong enough to withstand the elements and withstand after repair trauma, such as inadvertent weight bearing, um, like that. So if you're going to fix a leg fracture, it has to be thick enough and strong enough to withstand the accidental placement of the foot on the ground if the person's instructions were to put no weight on it, because it happens. The non-compliance rate is high in a non-war environment. The non-compliance rate with ideal instructions is going to be higher in a war environment. So you always have to overfix and overprotect. Um, Now, if a fracture is malangulated or malrotated, um, then that requires a closed reduction. That means you can numb up the fracture site, and my favorite way of doing it is a hematoma block, where I'll put a needle actually into the fracture site, numb up the skin first if I can, then put a needle into the fracture site, aspirate. You will get blood back. You want to get blood back because that tells you you're in the hematoma. It's contrary to what we're always taught about when you aspirate and you get blood back, and that may be in fact from a being in a vessel. But in this case, you want to drop a blood back. Um, and and you can tell that you're in the fracture site by hitting the bone before the fracture site and sliding along the bone until you hit the step off of the fracture, um, and then not penetrating any deeper, and you should then get blood back. And then I always use epinephrine in my lidocaine if it's available, because then I just listen for a quick change in the heart rate, because if I'm inside a vessel inadvertently, of course, the epinephrine is going to make the heart race. Um, I've never had that happen. It's if you hit the bone in a couple centimeters proximal to the fracture site and slide into the fracture site, it's always a successful hematoma block. And then go get a cup of tea. Uh, and by that I mean give it a chance to work. It could take a half hour for that to work. Then usually um, it's absolutely painless reduction. Um, what you cannot accept in terms of, I'm sorry, I'm going to change my location. I'm outside because my family's asleep, but the bugs have discovered my existence. Um, and it's rainy weather where I'm at, and uh, they're invited out. So once it's the bugs are eating me, you can leave it there. So once you get a steady hematoma block, um,
and you reduce it, that's usually successful, and have your immobilization material ready. If it's malrotated or excessively malangulated, you have to correct that. And that's done by the hematoma block, as I just mentioned. But what if it's not correctable? What if you get alignment that's straight as a board, but rotation is not acceptable? Well, you could always retry it while the hematoma block is in. You typically need a second person to stabilize above the fracture while you rotate below the fracture. Or if resources are poor, meaning you don't have an X-ray, you might have to either access rotation or plan for an open reduction and internal fixation where you can actually visualize it. In my environment, malrotation is not acceptable. We want forearms that are able to supinate and pronate normally. If a kid can only supinate to 90 degrees, meaning the thumb is straight up in the air with the elbow straight at his side, that's not acceptable because they'll never be able to touch their face at 90 degrees. You really want to supinate more for the palm to touch the face and to go to the bathroom. So activities of daily living have to be maintained and ensured. And so malrotation is not acceptable in any situation. You can get a perfect alignment of a tibia, but if the toes are aiming inwards, they're going to trip with every step. So if you cannot achieve correction in a closed environment, then you have to open it. And then usually the interdigitations of the fracture pattern will give you a strong hint, unless the fracture pattern is so broken. Our word for that is comminuted. If the fracture site is so smashed into multiple little pieces, number one, you would never get it close reduced in the first place. And number two, you lose that guidance of the interdigitation of the fracture fragments. If that's the case, you have to align it as best that you can. You use external markers like elbow alignment, matching the alignment of the distal radius bone if it's a mid-shift forearm fracture, or toe alignment versus the alignment of guide points on the pelvis and the hip to make sure that the tibia is correct. And if the patella is straight up and aiming in straight up and down, then the toe should be straight up and down. And the malleolus of the ankle could be can be adjusted such that the angle of the rotation is correct. And then you could fix it, bridging that gap. And that can be done again, either with a cast, or it can be done with a metal plate or an external fixator. The type of, are there any questions so far? I can't see hand raising or anything. I guess you'll have to tell me if somebody has a question. Regardless, along the talk, if anybody has a question, I will interrupt what I'm doing to answer it in real time. So if I can stabilize my camera here. So the next issue for me then is if I've made a decision to open it, then the issue is what type of fixation we have. Now, the stronger the fixation, the better, and the closer you get to the axis of rotation of the bone, the better. So if you have a long bone fracture, a pin or a rod down the middle of it is infinitely stronger than a plate on the outside of it. The principle for healing is an 1890-ish, I think, law called Wolff's Law. And you should know this law. It defines physiology in many organ systems, but particularly for bone. What it really says is bone is a living tissue. It's an elastic tissue. It appears rigid to us, just like glass appears rigid to us, a glass panel, but it's not. A glass panel is used in high rises all through the world because it flexes when bent very slowly. It's a fluid. It has viscoelastic properties, just like bone does. And those viscoelastic properties have to be respected. Uh, Bone heals by compression. It does not heal under distraction. And so, no matter what the principles of fixation are, compression has to be permitted as long as the bone is stable enough to be compressed. Now, when I was in Gaza and I took care of people that had a bullet that went through their femur, there were so many small fragments that obviously we couldn't compress anything. We had to just put those small fragments in alignment and pray that he and God will heal. And that's what I meant about the fact that there's a business in orthopedics. And what I tell patients is, my patients is, I don't know when you're going to heal. That's between you and God. My job is to align the fragments as best I can, and you and God are going to do all the work. I'm going to bill you for it. I'll charge you for it, but I'm not doing the work. You and God are. So you have to optimize your nutrition and eat good protein and good calcium foods if they're available. You have to not put weight on it if it's unstable. But generally speaking, it's an innate physiologic process. And that physiologic process is stimulated only by one thing, presuming that the instructions and the proper nutrition is available, and that is compression. So the more we allow compression, or the more we can induce compression at a fracture site, the better it's going to heal. So if I skewer a long bone with a rod down the middle of it, and I allow that bone to compress at the fracture site. So I fix it at the top and I fix it at the bottom of a tibia or a femur or a radius or an ulna. And I allow compression across the fracture site. Healing will be much faster than if I do not allow it. And that's why a rod in the middle of the bone with weight bearing on that bone is the most ideal situation. If the bone does not have a lot of pieces at the fracture site, that would not fall apart. Um, so if they do have a lot of comminution, again, our term for lots of pieces, then we don't allow them to put weight on it. And then we're just hoping that the soft tissues around the fracture will bring enough blood flow to those pieces to allow them to heal. And that's why children heal better than teenagers, and teenagers heal better than young adults, and young adults would heal better than me. The periosteum, or the blood flow coating of the bone, is thicker in a kid. You could actually sew it together. I'd hardly see it in my bone at 69 years old. Um, and, in humas, you could see it, but it probably would not be able to be sewn. But in a toddler up to probably 10 or 12 years old, you could actually sew it together. It's that thick, and therefore the blood flow is that more generous, and therefore the ability to accept a comminuted fracture without a more rigid fixation is much higher. There were children that I operated on Gaza wounds that had just gravel for the fracture site, and we aligned the bones, and the periosteum was intact. We just approximated the periosteum as close together as possible, and that bone will heal. It'll heal in 6 months, assuming no further trauma, as if they've never had a fracture in a toddler. As long as the periosteal envelope is intact, bone will heal. And that principle is exploited when we look at bone lengthening, a process invented by a Russian fellow named Elizarov. It's something you could Google when you get internet access. Um, and basically, when we want to make a leg longer, we deliberately uh, break the bone in the operating room, put pins above and below, and gradually distract the bone involved about a millimeter a day, and that tricks the bone. Now you need an intact periosteum here, but you trick the bone into thinking it's broken every day. And so 4 to 6 times a day, you lengthen it in divided sessions, a quarter to a sixth of a millimeter every session, and you turn the cranks on it, and it lengthens the bone, and the bone is tricked into thinking there's a fresh fracture every 4 to 6 hours. And so it starts healing over and over and over again. and you could lengthen a bone 5 or 6, 7 centimeters, um, and just by gradually lengthening it. It's a very successful limb lengthening procedure. Um, as opposed to shortening the other limb, which could be easily done in one session, but then all the soft tissues are shortened and the joints may not range normally. So lengthening a bone is always better than lengthening a traumatized bone, or even a congenitally shortened bone is better than shortening the contralateral side to make it longer, to make it shorter so that the lengths are equal. Um, but I raise that surgical scope only to show you and illustrate the value of the periosteum in youth. You could also lengthen a bone in me, but you're going to have to do it slower than a millimeter a day because, again, my periosteum, or my blood flow to the bone, is much more compromised than in a young person. So the take-home lesson here is bone has a blood flow on the inside of it. It doesn't have great blood flow through the cortex. It does have decent blood flow through the metaphyseal bone, or the spongy bone near the ends, which means that the soft tissue has to be respected, which is a nice introduction into trauma, because with trauma, we disrupt the soft tissues. And the level of the trauma has an important point here. For example, if you have uh, a crushing injury where the skin is opened and dirty, you never want to fix it that day. You clean it out, you provisionally stabilize it, whether it's a plaster or a fiberglass flab or a splint, or whether it's an external fixator, which you've probably all seen. And basically, what an external fixator is pins that go above and below the fracture with metal or carbon fiber bars. Uh, that will stabilize the fracture on the outside. It's nothing more than scaffolding on the outside of a crumbled building. While they're repairing the building on the inside, they add metal to the outside. You've seen it or seen pictures of it. Al Shifa Hospital has scaffolding on the outside of it now. And that's the external support while you're redoing the internal support. And that's all it does, while leaving the fracture site open and exposed so that you can deal with the tissues and you can deal with the blood flow, and you can repeatedly bring the wound back for attention. Once the wound bed, the soft tissues are clean, and the bone, once it's clean, and you know that it's the risk of infection is low, then and only then should you attempt internal fixation. And you never attempt internal fixation unless you have enough soft tissue to cover it. Don't put a plate on, which is superior to the external fixator, if you don't have muscle and skin to put over the plate. If you see the reflection of the plate at the end of the surgery and you can't close the wound, then you have a problem. You're guaranteed an infection. Bacteria will live on that plate. Bacteria make a coating called a glycocalyx, um, and that insulates the bacteria physically from our immune system. An example would be plaque on your teeth. If you don't physically remove the plaque and clean your teeth, plaque will develop. And what plaque is the glycocalyx of bacteria. And then they can destroy your tooth under the gum line because the bacteria are insulated from your natural immune systems. And your strongest immune systems, believe it or not, are in your mouth. But people still lose teeth because of poor dental care and poor cleanliness. And that could happen to a metal plate as well. Bacteria will adhere to it the same way they would adhere to an artificial mitral valve with somebody with an infection if they have a pig valve, and that would have to be changed. So don't do a surgery that will, in a very superior way, immobilize the fracture if you can't cover the plate. How do we cover plates? Well, the best way is to use the local tissues. Usually there's enough local tissue to cover it. Sometimes we have to cover it with muscle, but not skin, and that's okay. You could always skin graft days later. There just has to be complete coverage over a plate. For example, I have a patient now in North Carolina with a tibia fracture. I could not cover, it was a gunshot wound as well. I could not cover the tibia uh, completely because the skin was gone by the exit hole. The exit hole is always bigger than the entrance hole. Um, and there wasn't any skin left. But there was a medial gastroc muscle. And I uh, was able to take the medial gastroc muscle, detach it, flip it around, and cover the bone. Now, so the gastroc muscle doesn't have skin on top. Okay, I can live with that. I can come back 2 months from now and put skin on top of that as long as I keep the outside of the muscle moist and clean. Um, but at least the plate is covered with a blood flow, which means it can deliver white blood cells, which means it can keep it clean and moist, and the bone nutrified. So don't put a plate on unless you can cover it, and if it has to be covered in stages, so be it. But almost always, local tissues without a muscle flap, like I described, are necessary. Now, we saw some patients there that we evacuated to Egypt because they need what's called a free flap, meaning the bone was fixed, but it was in a location where there was no local muscle that could be covered. And so typically we take a latissimus dorsi muscle from the back with a blood vessel attached and sew in that blood vessel to a native blood vessel and cover it with the latissimus dorsi muscle. And that allows us to get soft tissue coverage, but we don't put a plate on until that muscle harvest is available. And so either you do the latissimus dorsi flap first and make sure that it lives and then come back, open one edge of it and fix the fracture, or you fix the fracture and cover it with the latissimus dorsi in the same setting. All of which are something that's not going to happen in a war zone. Um, and that's a rare surgery to occur even in my setting. So usually it's local tissues, and rarely do you have to get muscle from the region on what's called a pedicle flap, meaning it still has blood. You keep the muscle's major blood flow going. And the part distal to where that blood vessel comes into the muscle, you rotate that over the plate. And the principles of muscle flaps are really meant for another lecture. Um, the principle, though, of having to keep the plate covered is mandatory to understand. And so external fixators are overwhelmingly the most common type of fixator that you see in every trauma zone and war zone. I went to a trauma zone, non-war zone after the Haitian earthquake, and that's all we put on were external fixators. It was a rare incidence to put on a metal plate because all the wounds were crushing injuries and all the wounds were dirty. And so the charge was to stabilize the bone uh, and stabilize the soft tissues by stabilizing the bone. Clean it and then bring it back to the operating room or do it at the bedside under local anesthesia. Clean it again and clean it again and clean it again. You can't clean it enough. And only when you see healing granulation tissue is it time to go back to the operating room for a definitive fixation. And you have to plan and see if you have enough local soft tissue to cover everything. What happens in a situation where there just is no chance for soft tissue coverage? And um, Sometimes that results in an amputation. Um,
Doctor,
I,
sorry,
yes,
we've got a question. Someone
yes,
asked if you could elaborate on why we need weights to fixate a bone and how this is done.
yes. When you say weights, do you mean traction weights or do you mean compression to stimulate the healing of a bone? Well, I'll answer both to make it simple. Um, Part of the achieving alignment of a bone is traction. Um, during the wars of the 1800s, a femur fracture from falling off a horse or a musket ball was a kiss of death because of blood clots. And so quickly the concept of traction became known, and it didn't really get perfected until a fellow in England developed this metal sleeve that you put a leg in that had the upper end padded like a crutch would be padded, that would go around the pelvis, push into the groin, miss the genitals, but push into the groin and on the pelvic brim. And these 4 metal bars would go distally, and then they would wrap cloth around the ankle and pull to the end of that bar till the leg became straight. And often people would heal like that. And that's good. And the risk of blood clots and things like that were there. And in the hospital, what we've done is put a pin through somebody's heel bone or their distal tibia with a femur fracture and their proximal tibia, and put weights across the end of the bed, jugs of water, whatever weight that you could find, bags of saline, any weight that you could find to pull longitudinally on the fracture so that the bones would be maintained in closer alignment until you can get them to the operating room. You really have, it's almost impossible to get a bone in alignment in the operating room if they sat for a week or longer with the bones overlapping. The amount of scar tissue and muscle contracture is too high. So you'll see people in traction in bed with weights. And that was very common in my youth. And it was very common in the European Gaza hospital. It's not so much common in a modern orthopedic setting because of the advent of intramedullary rods and our ability to fix a fracture within hours of it happening sometimes, or minutes of it happening, we could literally do. But even then, it would be almost impossible to do if they sat for 2 weeks with the bone foreshortened 3 centimeters on each end. It would not fix very well or very in an easy way. Now, the other part of the question was weight. And so we could use weight in initial trauma to distract a bone so that it's brought back out to length. But the weight bearing that stimulates healing is done first by rigid fixation. If you put a rod down the middle of the bone, the bone can slide up and down that rod, and so you have controlled compression. The screws at the end of the rod can be either dynamically fixed or statically fixed. And what I mean by that is you could put weight on it, and the bottom screw can either go at the bottom of a hole, this being a big hole, you could put it deliberately at the bottom of a slot in the rod so that when they bear weight, it slides down to the top, but you still have the control of the rod. Or it's a perfect hole if you have perfect alignment and everything is tight and compressed as can be, and then there's a circular hole in every modern rod. There's a circular hole that once the screw fits in it, it is absolutely a rigid fixation. And that's what you would do if it's horribly comminuted. If it has lots of small pieces, you don't want them to put weight on it because it'll foreshorten too much. So that way you want to statically fix it through the circular hole at the distal end of the rod. Super rigidly fix it only with static holes at the proximal end of the rod. I don't think any company in the world makes a rod that has oblong screw holes that would dynamically fix it proximally. So in a tibial rod, you fix it very rigidly at the knee end, at the proximal end, and at the distal end by the ankle. There's always a circular hole at the bottom, and right above that circular hole is an oblong hole that if you put the screw at one end, as you bear weight on it, it will slide to the other end. So it's still maintain rotation, but allow safe compression. Under that safe compression, the bone is stimulated to heal. So if it's just a simple crack and it's stable, you can allow full weight bearing on a fracture, and uh, and it will heal much faster than in any other scenario. God's stimulus for bone to heal is compression. It actually puts an electric charge across the bone. It stimulates osteoblasts. Stem cells are converted under compression to make osteoblasts and modulate their activity, wake up sleeping and hibernating osteoblasts to work more. And of course, the fracture hematoma has an awful lot of stem cells in it, and that helps. Going back to stem cells, the advantage of an intramedullary rod for a closed fracture over a metal plate is that you keep that hematoma, which has all the stem cells in it. If I have a closed fracture, meaning the skin is intact of any long bone, and I can put an intramedullary rod in it, it will heal way faster, with or without weight bearing, than if I have to open it up and put a plate on it. The reason why a plate heals slower is because I wash away the hematoma. I wash away all of God's given stem cells that migrate to that area immediately and come from the bone marrow that's local, that will turn into healing bone. If I wash away that hematoma, I can put the most beautiful plate on. It can look fabulous, textbook perfect on an x-ray, but it will heal slower than a poorly placed rod where I maintained the hematoma. So if it's not an open fracture that demands a washout and therefore washing out the hematoma, keeping the hematoma in place by putting an intramedullary rod not only gives you stronger fixation because you're closer to the axis of rotation by a factor of R to the fourth, then but it also preserves the hematoma. The fixation is infinitely stronger. Well, it's R to the fourth stronger. That's not infinite, but it's R to the fourth, which is substantial. An example to you would be if you hold a bucket of water down by your leg, you could all hold it for an hour. Hold it out with your arm stretched out, and that same poundage of bucket of water is not going to be, you're not going to have the strength to hold it out very long. The closer you are to your axis of rotation, always the stronger a fixation.
Dr. Perlmutter, we've also got another question, which is saying, can using weights cause compartment syndrome?
No. Well, yes and no. There's two types of compartment syndromes. One, and overwhelmingly the most common, probably 99% of them, are caused by trauma. Outside of every muscle is a thin fascial tissue called fascia. And it maintains the shape of the muscle and maintains it within its own compartment. That fascia is tenacious. If you cause trauma to that muscle and it bleeds, or you rupture an artery in that muscle's space and it bleeds, you get what's called a compartment syndrome, when the pressure within inside that fascial compartment exceeds the venous pressure. So if you're above 30 centimeters of mercury, for example, the veins will compress. And then the pressures go exponentially upwards because you can't drain that compartment. So you're still bleeding on the inside. You've blocked the exit of blood on the outflow of that. The pressures get higher and higher and higher. And sooner or later, the muscle cells within and the nerve within that compartment die. And that happens within a couple of hours. The younger you are, the longer you can survive it. The older you are, the less time you could survive. And we treat that by doing a simple fasciotomy where we make long incisions along the bone. We identify every muscle fascia and open it. The muscle spreads. The incisions on the skin spread dramatically, and often they can't be closed. over half the time we have to skin graft those because you just cannot approximate them. It spreads so much and never comes back to its normal shape. Often we'll skin graft them and they come back a year or so later and it's gone back to its normal size, and we can excise the skin graft to make the scar look nicer. But genuinely speaking, in a ubiquitous trauma setting, we open it up and then put clean dressings on it and worry about the skin grafting later because it's probably not a clean wound. The other type of compartment syndrome is called exertional compartment syndrome. That happens in eclectic athletes. Usually happens in the lower leg. It's much more common in the lowest part of the upper extremity or the hand than in the upper extremity because the arteries and the veins are bigger in the upper part of the extremity, and it's very, very uncommon in the thigh. In fact, in the thigh, I've only seen it when there was a vascular injury, an arterial injury. I've only heard of it when there's an arterial injury, such as a gunshot wound or a crush. And in the lower extremity, from the knee down is where compartment syndrome is the most common. Probably greater than 95% of compartment syndromes occur. Probably greater than 99% of compartment syndromes occur in the lower extremity. And that's the only place where I've ever heard of an exertional compartment syndrome. Usually in eclectic athletes that don't know when to stop working out, and the blood flow to a muscle exceeds the fluid in the muscle from edema from the workout, contributes to it. The venous outflow gets compromised, and they either have to stop what they're doing to let the pressures normalize and it gets better, or they have to have a emergency compartment release, which I've only seen once in my life. It was in an ultra marathon runner who was goal was to run a marathon a day for a week, and he was running through my town, and he developed a compartment syndrome in the ER. And I emergently took him to the operating room and released his compartments. But he had already run like 6 marathons in a row, and ended up in my emergency room with an exertional compartment syndrome. Most exertional compartment syndromes give pain that make you stop. Yeah, you elevate ice, and it usually gets better on its own, and it recurs, and it gets better on its own. And then they come electively to your practice, but it can happen. But that's strictly a blood flow issue. I hope that answered your question. I personally may never see another exertional compartment syndrome in my life. They're that uncommon. I see somebody having a hand raised. Is that true? Is there another question? Let me know, Yuman. I'll move on otherwise. So we were talking about the weight bearing and the principles of fixation, and that's true for where we put a plate as well. All modern plates have 2 types of screws in them as well. They have a round screw and they have an oblong screw. The round screw goes into the bone, and where it hits, it hits. So when we use those round screws, what we have to do is put the bone in place. We have to compress it, typically with bone clamps. And what I'll do is drill 2 small holes in the bone, just a millimeter big, and put a pointed clamp in on both sides of those holes, and clamp symmetrically with bone clamps to bring those bones as close and as tight as I can. I'll put screws in through the plate, and excuse me 1 second, I have an incoming call which I have to ignore. I apologize. It's the operating room nurse for my case this morning. And then I'll fix one side of the bone very rigidly, clamp the 2 bones together as tightly as I can, So I'm maximizing compression and then fix the other side. To augment that, the plates have an oblong hole in it as well. And the principle of that is you can use that oblong hole to increase compression. And so all modern plates are typically called compression plates. The term compression plate has kind of fallen out of favor. 15 years ago, I would ask my operating room nurse to give me a compression plate or a standard plate. Now all plates are compression plates because they all have these oblong holes in them. And the principle of how they work is the bottom of every screw has a shape to it like this, with the threads going down the shaft of my forearms and the screwdriver going at where the top of my head is showing, with some type of Torx hole or something like that, or a hex head hole or a slot. But the bottom of the screw is shaped like this. So if you put the screw right where my forearm is, and the plate has an oblong hole also with this shape here, as this bottom of the screw hits that wedge of the plate, and you advance the screw. If you start here and you advance the screw down, it pushes the plate this way and adds to compression. So you can get an extra millimeter of compression, which is a lot if you've already squeezed the heck out of it and it's already highly compressed. You can actually maximize that compression with a compression plate. And it's hard to describe, but it's easy to visualize. But just the takeaway lesson is we have methods in the operating room that augment compression. And then there are things that we have done historically with wires that augment compression. The classic bones that are fixed with wires while you're maintaining compression are the olecranon, which when you bend the elbow sideways, the olecranon would tend to fracture. If it was right through the end of the olecranon, would tend to pull apart. The same way that if a fracture in the middle of the patella would pull apart. Okay, so the principles of fracturing have to be understood here. To reverse those, to understand the principles of compression with wires. If you took a pencil and you bent it, a little piece of wood usually shoots off in the other direction, and it breaks like this. If my fingers come together as a whole pencil, if I put pressure on the pencil, the bottom side is being compressed and the top side is getting tension. And so that fragment, usually from the 50% line through, shoots across the room. And as it shoots across the room, the compression part usually crumbles. So you can see a butterfly fragment is what we call it, that pops out of the top, and smaller pieces, or sometimes it doesn't break at all, just cracks. Smaller pieces are at the bottom. So when we fix it, and let's say this is a kneecap. A kneecap always cracks where the knee is below and the outside of the knee is above, where my face is showing. When you bend a patella, it always breaks this way. So what we want to do is exploit the natural forces in the joint, because we want it to heal by compression. So again, when you bend a patella, when you bend a knee naturally, a natural patella, the top gets tension forces and the bottom gets compressive forces. So when you look at an X-ray of a patella, you'll see that the bony cortex is much thicker at the bottom than it is at the top, because it gets thicker because of Wolff's law, because the bone responds to the pressures on it, and the thickest part of the bone is that which gets the most pressure on it. So all we have to do is secure the top. If we fix the top, the compression, just by telling the patient it's important that you bend your knee, just bending their knee is going to compress the bottom. But what we want to do is not let the top open up. And that's the same for an olecranon. So we can do that, which is called tension band wiring, not compression-sided wiring, but tension-sided wiring. And so basically what we do on the top of the patella or the outside of the olecranon is we'll put a figure-of-8 wire that goes through both bones, through this side and this side, through the bone, outside the bone, crossing, making a figure-of-8, and we twist tie it so that it gets super tight on the tension side. So we're actually compressing the tension side. And that's the purpose of that is just to hold the tension side tight together while they're bending the knee so that it doesn't open up. The bottom side will heal just by telling them, bend your knee because it's going to compress. And so we're using natural motion to give us the compression we need, and we're only giving tension to prevent the opening up of the bone and creating stability. And the only place we ever really do that is on a kneecap and an olecranon, which get tension by stretching open. Everything else is rigid fixation. Any questions now?
Yes, Lana, if you want to unmute, you can ask away.
Oh, okay. The doctor was saying that these type of suture and fixation can be done on the kneecap, and what else? What is the other area?
The elbow bone, the very tip of the elbow is
Okay.
called the olecranon, and the side view of the olecranon here, as I bent my elbow, if I fractured the tip of the olecranon, which goes into the joint, overwhelmingly the most common fracture pattern, the two bones will separate. But I just have to get them to come together on the articular side and put tension wires to stop it from opening up. And the instructions are no splint on the patella either. Get them bending. Every time they go in this direction, they're compressing the articular side, and the tension band prevents the tension side from opening up.
Okay,
The premise being that bone cells that are healing don't jump over a gap. And that's true for skin cells and tendon cells. Basically, what we do as orthopedists is bring point A to point B and let the patient and God do the healing again. And what the tension band does is very simple and intelligently allow the side that would open up or stop the side that would open up from not opening up. So the full width of the bone stays in contact, where the full width of the bone, the kneecap or the olecranon, is staying squeezed together. It will squeeze itself together at the articular surface just by making them bend. The tension on the articular surface is 16 times greater right now than like this. Same thing for a kneecap. When you go up and down stairs, you put 16 times of your body weight and force across a kneecap. And that force is on the compression side, not the tension side.
and everything else can be done by what? What we can use for the other types of injuries?
I've never seen tension band wiring on any other joint except the kneecap and the olecranon. Other than that, it has to have rigid fixation by plates or screws.
Okay, thank you.
You're welcome.
And
Are
we
there
have
any?
questions
Go ahead.
in the chat that do we remove the rod that we use to attach different fragments of bone, or does it just stay there?
We typically leave the rod in forever. The only reason to take out a rod is if, for one reason, one of the screws that are holding the rod together are symptomatic. For example, if I put a rod in a kid's elbow and a screw is palpable right under the thin skin at the elbow, we may take out the entire rod or take out just the screw. And that's true for most modern plating. We typically leave the plate in forever. Most modern plating is titanium. Older plating is stainless steel. The reason why we used to take out every steel plate is because it's too rigid. The advantage of titanium over steel, and that's true for rods and it's true for plates, titanium is flexible. In biomechanics, there's a concept called Young's modulus. The full term is Young's modulus of elasticity. Every object on Earth has an elastic Young's modulus. If Young's modulus is very high, and you attach it to bone with a Young's modulus in its 90s, whatever, I don't remember the units of measurement, but let's say that let's just pretend that I know what I'm talking about, and Young's modulus of bone is 100. Because bone is a living structure and it has a level of flexibility before it breaks. But let's say this tibia bone in this one person has a Young's modulus of 100 to make up a patient, to make up a bone, and to make up a number. If I put a steel plate on that bone to fix it, and that's the Young's modulus of that plate is 1200, then the bone, when we allow him to put full weight on it, the bone is not doing any work. There's no weight going across that fracture site because it's held above the fracture and below the fracture by the screws, and all the weight bearing is going through the steel plate, which is much more rigid, and transferring the load from the lower end of the fracture to the upper end of the fracture through the plate, through the screws, and bypassing the fracture site. That's with a rigid steel plate. So we would wait for the bone to heal substantially, then take the steel plate out in a year, so that as the child or the adult grew, they would then slowly respond to the weight bearing once the plate is removed, and the bone would get stronger. Now we use titanium plates. The modulus, Young's modulus of elasticity of titanium is so much closer to bone. In fact, of all metals, it's identical to bone. And we even shape the plates by scalloping out the sides to make it thinner so that the intended bone it's going on has about the same Young modulus of elasticity as the bone. So we never have to take them out. When you put weight across a fracture and the fracture is a femur bone, the plate is designed to have such a similar modulus of elasticity that the bone itself is load sharing when you put weight on it. Clearly, the plate is still doing some of the load bearing, but not nearly as much as a stainless steel plate would. And of course, it doesn't have any of the downside of the heavy metals that are in a steel plate. There's no cadmium, there's no palladium, there's no nickel that sometimes can leak out of plates and cause potentially cancers. That has been a problem as recently as just 10 years ago. So the more that you can get closer to the modulus of elasticity and still maintain excellent compression and stability, the better it is. And so by all means, titanium plating is far superior to stainless steel plating. And then, of course, there's small variations in plating techniques. If I had a fracture in the middle of a bone, I can put screws right up to the edges of the fracture. Well, that doesn't make sense because it takes a load off of the fracture. I'll put my screws way back off the edge, and I'll put 3 screws way up above the fracture, 3 screws way below the fracture. It's known that 3 screws above and 3 screws below typically give fixation, but I'll leave 3 centimeters on each side of the fracture unfixed because I want that titanium plate to have a little bit of flexibility at the fracture site, which transfers most of the load bearing. If that plate flexes, it transfers it to the bone. And so I'm letting the bone enjoy more of the load bearing if I have to use a plate. Of course, if I use a rod and I skewer the fracture and I have no fixation at the fracture site, that makes it even more ideal because, again, I haven't washed away the fracture hematoma. I'm keeping God's healing stem cells in place. I'm allowing the bone to compress along the governance of a rod right through the middle of it. If it's a stable fracture, and if it's not a stable fracture, I'm at least not interrupting the hematoma. and I'm keeping the fracture site clean by not opening up the skin, something very important in a war situation. And if I can let them put weight on it, the amount of healing by not disrupting the hematoma and by letting them put full weight on it is astronomically faster and superior.
And then another question is it true that if bones with rods get broken again, the limb would most probably eventually be amputated?
If what gets broken again?
If bones with rods get broken again.
I've honestly never seen a bent rod in my life, even in disaster zones. It's much more likely that you'll break above or below it. So if you get in a trauma situation, you're more likely to break at the bottom of the rod. The rod adds ongoing, although it allows it to heal in compression because it's the bone is being compressed in the line of its load bearing. It does add flexibility, stability, and it does add rotational stability. So though I've seen people in horrible car accidents, ones that were so bad they died, but the rod that was in their femur or tibia didn't break, but they broke above it and below it. So so to the point to the question is it more likely to get amputated? I would say no. It would be almost impossible to take a bent rod out of somebody without opening up the bone at the fracture site and cutting the rod and pulling it out from the individual ends. You'll never back out a bent rod and you can't rebend it. I've never seen a broken rod at a fracture site. So I doubt it's something anybody else has seen either. So it's not really a clinically relevant situation. If the trauma was so bad that somebody's going to bend a rod, they would have broken that bone so badly because the rod is so much stronger than the bone in bending. They would have broken it so badly that they would have required an amputation by the level of trauma that they experienced, not because of the broken rod.
Thank you so much, Dr. Perlmutter. Does anyone have any other questions? And if not, then I can start making a WhatsApp group chat where students can join and they can be in conversation with you, where if they have any other questions during their treatment, they can ask you, if that's all.
That's right. And that we can keep this channel open for years as far as I'm concerned. And I'm certainly willing to repeat this lecture again on orthopedics. I'll await your advice on that. And I could also include other disciplines. Say, for example, you do not have a plastic surgeon. I could get one for you. I can get trauma surgeons. I can get cardiothoracic surgeons. I can help fill gaps in your schedule.
Thank you.
And any way I can help you, you know I will.
Definitely.
And if you want more orthopedic and wound care lectures, I'll be happy to help with that too.
Definitely. I think when I spoke to the students, they were quite keen on a lecture on flap and wound control, which I think was one of the options you gave. So after this, we can coordinate when would be the best time to maybe deliver that lecture. But thank you so much today,
If this time works well for you, it works well for me.
Great, amazing. Thank you so much. It was really nice. Really nice to see you, and hopefully.
Okay, you too.
And if anyone has any questions, let me know, and I'll make the group chat now so you can all be in contact with Dr. Perlmutter. Thank you so much.
And you'll open that chat up to other students as they come available to you?
Definitely, I will.
Okay, you bet. Take good care.
You too. Bye-bye.
Bye-bye.